This conference will now be recorded.
Okay, you're welcome to go ahead and start the meeting now.
All right, it's 3:30 on October 14th, 2020, and the Telehealth Committee will come to order with the following members present: Dr. Schottenstein.
Present.
Dr. Bechtel. Mr. Ganadakis.
Present. Present.
Dr. Schoen.
Present.
First order of business is review of the minutes. May I hear a motion for approval?
Moved. So moved. So moved.
Dr. Schottenstein, Dr. Schoen. All in favor?
Aye. Aye.
Opposed, same sign. Minutes are approved. All right, now we're going to hear about the applicability of telehealth to respiratory care professionals. I don't know who is going to do that for us, but whoever is, please take it over.
Tribal, if the chair would permit, I'd like to kind of introduce the topic and then have Dr. Kakarala provide us with some valuable input related to his pulmonology experience in this area. So just to kind of tee the issue up, we were provided with a document from the Ohio Society for Respiratory Care requesting that respiratory care professionals be added to the list of practitioners in the 679 bill that we've been discussing to be covered as providers under telehealth. Board staff, that document, that request was included in your materials. It's about a 1.5 page document. Board staff has reviewed the document with Dr. Kakarala, who we've asked to attend to provide some information and insight as a pulmonologist, and would like to at this point ask if he could share any comments he had on it, particularly as to whether the procedures listed in paragraph 2 of the document seem like appropriate uses of telehealth for a respiratory care professional, and whether this would be done by physician order.
Sure. Thanks, Nate. So a couple of things. One, so right now, prior to the pandemic, there have been private pulmonary critical care groups or pulmonary groups and health systems to a lesser extent that use respiratory therapists for inhaler instruction, asthma education, and various other disease states, cystic fibrosis, etc. And though it's rare, people that are on home ventilators and things where they get home visits or other phone visits or other types of things. So now that we're having a significant number of patients having televisits or phone visits, as long as it's ordered by a physician and has physician oversight, I think that it's really substituting what's already happening in clinics and offices around the state, where patients get good inhaler instruction and other things that just augment the care that they need and is reminders on how to do just necessary things to continue taking care of themselves. So obviously, I have no idea if what happens in terms of is there a separate billing or anything like that. I don't think we should get into that or make any remarks. Whatever is being done already should continue being done. I don't think that it's appropriate for us to weigh in, but certainly as long as there's a physician order, I would like the respiratory therapist to be able to do televisits or phone visits that's within the scope of their practice.
So the board legislative staff has been meeting with the senators Hottinger and Hackett, the vice chair and the chair of the Senate Insurance and Financial Institutions, and have shared the board's proposed amendment language that this committee had approved for Jill Reardon and Chelsea Wansky to start moving forward. So at this point, the request of the committee that I would make is to discuss and provide feedback to the to the Senate committee chair on whether the Telehealth Committee approves the concept of respiratory care professionals being one of the approved providers under House Bill 679. And this will enable Jill and Chelsea to communicate that position in the appropriate way to the legislature.
Any thoughts?
Sounds like we'd be right to approve and recommend.
I agree.
Anyone opposed to that? All right, do we need a Dr. Bechtel?
I'll go ahead and move forward.
Do we need a formal vote?
Yeah.
Dr. Bechtel made a motion.
So.
Anyone, oh, sorry. Anyone second?
I'll second.
I'll second. Oh, my pleasure.
Favor?
Aye.
Opposed, same sign? All right, motion passes. All right, thank you. Thank you, Dr. Coccarello.
No, thanks. Yeah, appreciate it.
Very helpful. All right, next we're going to talk about the Medicaid telehealth rules. And Nate, are you going to take that?
Yes, Dr. Feibel, thank you.
Thank you.
Originally, this item was strictly an informational item, and it really is. I just have more information for you than that's come in within the last day or two. So, per our discussion at our last meeting, the board staff wrote a letter as a comment, a formal comment to the Ohio Department of Medicaid regarding their proposed rule, and the comment really just provided this committee's statement on what its priorities are in terms of what should be the guardrails around telehealth, and with that provided basically that position was articulated in the draft amendment that this committee approved. So that was all given to Medicaid and provided as our formal comment. As an update to that, I received an email just yesterday from ODM alerting us that ODM has now completed a revised filing of the rule. This occurred on, we were told of this yesterday, but the revised filing occurred on October 5th. The email states that at this time, ODM does not intend to require patients to have an in-person visit before a telepost to the State Medical Board of Ohio implementing such a requirement. We believe with the added language in paragraph C2 of the proposed rule, it will be complementary and not in conflict with any future by the board. So I can provide this revised rule to anyone who requests it from the committee, certainly. What I was able to do in the short time I was able to have to find the rule and all the information on it is that, in fact, ODM did amend their rule to say it is the responsibility of the practitioner to deliver telehealth services in accordance with the rules set forth by their respective licensing boards. This was in the original draft. What they have added, so they must deliver in accordance with the rules set by their licensing board and accepted standards of clinical practice. So I do feel like our comment regarding standard of care, did make some positive difference in their revised rule. In addition, they have also clarified some responsibilities about practitioners who have been rendering telehealth to a patient for longer than 12 months. The initial rule stated that there should be at least an annual visit, but they also put in additional language here about if that annual visit can't be accomplished by that practitioner, there should be a referral for another provider to do that annual visit that's not an emergency room visit. They've added residents as approved providers of Medicaid telehealth, and they've added a catch-all provision, very expansive provision that any other practitioners could be considered to be under telehealth if authorized in a Medicaid rule. And then they've clarified some other definitional language, but those related to being very specific that telehealth should involve interaction with a patient. I'm happy to provide that information to one and all in an email down the road. I just wanted to make you aware that things are still sort of evolving with that Medicaid rule, and I feel like our comment did have some positive effect. So, any questions on that?
That's great. Any questions for Nate? I have one quick one. One of my worries is that the medical board is going to be too restrictive with regard to telehealth compared to the other licensing boards. And I didn't know if this is a place where good communication between the nursing board, I don't know if the pharmacists are going to be in there, the pharmacy board, the psychology board, whatever other boards potentially can deliver Medicaid telehealth services. We should all hopefully be on the same page about this to try to really get some guidelines around it. And I realize we don't regulate those practitioners, but it would be nice if there was some open dialogue and communication between the boards. And I don't know how to make that happen. And I would be curious what the other members of the committee think about that.
So thank you. I'm guessing that the psychology board probably it would not surprise me if they were in favor of the initial evaluation being over telehealth. Because there's no physical, exam. So they probably, I'm guessing, are going to be in favor of, having that requirement.
What about the nursing board? Probably our biggest issue. Nurse practitioners can do it, but we can't, type of thing. Thoughts?
Maybe we could just sort of reach out and, see, where they're at with this. I mean, we have good reason to, prefer the initial point of being in person. Presumably, they would share those good reasons. Maybe we can just, place a call and find out where they're at with it.
Okay.
Yeah. I think, if I may jump in, I think that's appropriate. I think it's time that we do shop this with the other boards. Some it will be a little more applicable to because it's that person, or there is a touch, if you will. Others, it won't be. And, frankly, then the Medicaid rules probably give them that flexibility to allow for pay your services accordingly. I'm happy that they did make some adjustments for us. That's great news. And I think that I think it's fair to say that we can even be a little bit pushy with the nursing board on this, on where we are and what we think and feel. So I think, Jill and her group can absolutely reach out to them and have those discussions on what we'll be going forward with. And it would be fantastic if they would come along with us on this.
That'd be great. And I'd be happy to talk to anyone at the nursing board on the board level if they want to talk from board member to board member too. So Jill or whoever reaches out, I'm available.
Great.
All right, great. Next item is the frequently asked questions, which Nate has and the staff has worked very hard on, and we appreciate it. Nate, you want to take it away?
Sure.
Thank you.
One quick thing that I wanted to tie up on that last issue. Dr. Bechtel had asked the question last time about prisoner health care related to that Medicaid rule, and I just wanted to be responsive. It turns out that there is a Medicaid rule that specifically states that Medicaid will not pay for services provided to an inmate who is an inmate of a public institution. So that's by rule, and that's pursuant to a 42 CFR 435.1009. Ohio Department of Rehabilitation and Correction has a policy that talks about they will provide medical care to inmates, and that they've also developed a plan where, based on the amount of money that an inmate has on the books, that inmate will be required to use a copay. So, merely informational to get back with you on your previous question. Sure. As to the FAQ issue, we had received some inquiries from a law firm related to various scenarios around telehealth prescribing and our FAQs related to 4731-11-09. Before I launch into this issue, I wanted to just share a communication that Dr. Schottenstein had reached out to me and had expressed some concerns with providing legal advice to a specific law firm that other law firms, individuals might not be privy to. And so I don't know that this changes our discussion as much as how and to whom we disseminate the answers that the board ultimately decides on. I would defer to Dr. Feibel as to how the committee should proceed on that. This one option would be, instead of responding directly to the law firm, the committee could use this discussion to provide guidance to me or other staff to draft FAQs based off of our discussion that the committee could review at its next meeting, so that those FAQs that are based off of these scenarios that were provided to us by this law firm would be accessible and available to other law firms or individuals who are interested in this. So
what is committee's thoughts on this?
So if I may,
Yes.
I had reached out to Nate about this because I just wasn't sure that it was appropriate for the medical board to be giving legal advice to a law firm. And I just sort of wanted to clarify as to whether or not that was our role. One concern I had is, that, excuse me, we provide legal advice to one law firm, but there are other law firms who are not privy to that advice. So one law firm who gets that advice goes in one direction, and the other law firms go in another. And sorry, the other concern I had is, that there's an unintended consequence. That at some point, our legal advice to the law firm ends up being used in a way that's contrary to the interests of the medical board. I don't think that's likely. Substantially, the language that Nate proposed just refers back to the rule in the FAQ. But at the same time, once we give legal advice, it's kind of out there and we can't take it back. So my thought, and what I communicated to Nate, was that I thought it would be reasonable to simply tweak the FAQ, right? Because that way there's a common playing field for everybody. We could, address the concerns that need to be addressed in the FAQ by tweaking a law firm. But then everybody is, working with the same set of facts. That was my thought.
Yeah, I certainly like that. I don't like answering a specific person or question. I don't know how that works with regards to licensees, because we have given formal opinion to licensees. If we're going to go down that route, I don't think it's up to this committee to give those answers to that question. I think it would be the whole medical board if we decided to go down that route. And I would think any of these frequently asked questions probably should be vetted through the entire board at some point. But I think it's a good idea to have Nate come up with frequently asked questions, and you can use this as a template and bring it back to us for our review. What do other members think?
It's a good approach. I agree with your opinion, Dr. Feibel, to proceed, and then we can review.
That sound reasonable, Nate?
Sure.
Okay. Do you want to go through this document, or should we let you work on it some more and come back with a more generic document?
I guess I would say that to the extent you all have had a chance to review the document and could just give me some feedback if you're in agreement with sort of the general direction I've headed on these three scenarios, then that would be helpful as I draft, so I have clear direction.
Did I? Go ahead, Dr. Sling.
No, I'm okay. Thank you.
Anyone else? All right. Anything else from you, Nate?
No, I can start drafting FAQs around the proposed language that I've put in the memo. So I will bring back in a different, more globally accessible format.
Great. All right, and that'll be our next board meeting. If this bill starts to move through the committee quickly, and you need our help, we're all happy to reach out where we need to. So please keep us informed of over the next 4 weeks.
We will. Thank you, Dr. Feivel.
Thanks. Anything else from the committee? Motion to adjourn?
So moved. Second.
All in favor?
Aye.
Aye. Have a great 4 weeks, everyone. Be well.
We'll move
All the
forward.
best, everyone. See you.
All right. Bye.